Hello, everybody. I am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. We have an exciting faculty tonight, an exciting topic, the topic of cement and press fit in triple tapered stem, a bit of a surgeon debate, maybe more of a surgeon discussion among friends. I would like everybody to know that if you have questions, please put them in the chat. We will call on you and ask you to give your question. If not, we'll ask the question for you. I'll start off by introducing have the faculty introduce themselves. I'll go in alphabetical order. Jim Ballard.
Yeah, my name is Jim Ballard. I'm from Portland, Oregon. Been in practice for 23 years. Have been through all different iterations of femoral stem use. Trained to never use cement. Then I used cement. Then I didn't. Now I'm a good mixture of cement and cementless.
All right. All right. Mike Bolo.
Yeah. Hey, Mike Bolognesi. I'm at Duke University Medical Center, obviously a hip and knee surgeon, and I'm our division chief down here. And excited to talk about this. Yeah, I mean, I'm a current user of a triple taper for primary hip, but I think this discussion about cemented versus cementless and whether, and not just pertaining to triple taper, but I think the whole concept's of something we're still trying to figure out. So I'm excited to talk about it tonight.
Excellent. And Rob?
All right. Hey, yeah, Bob Sershon, Anderson Clinic out in Virginia here near DC. Obviously home to cementless hips. So that's about 99.99% of my practice.
All right. I wonder what the 1% are feeling, you know?
It's a pathetic case, I'll tell you that much.
All right. All right. All right. So, Bob, since you started us in this way, tell me a bit about the tapered stem in general, just in general terms, you know.
Yeah, I mean, I think it's a nice evolution of what we've been seeing over the years, right? I mean, if you want to go all the way back to, 80s with the AML, or these, long cylindrical, extensively coated stems. And then eventually you kind of graduate into your type 1, type 2 stems, much shorter. You're getting away from some of your Riemann broach techniques. Maybe getting a little bit of a shoulder cutout, in the 90s with some of your big four, whether it's, taper lock, tri lock, any of those. So then I think, at least in the Europeans, right, you have your compressive broaches, right, your Karai type stems that they've been using forever. And the collar coming out there as well, not just in the US with the AML. So you've got all these things, and I just think that naturally, with how well the summit was working, the adoption, the widespread adoption, I would say, of anterior in the US, companies started to say, what can we do? And I think that it was a nice evolution to take something that, something like a type 2 stem that was a Riemann broach, make it shorter, because I think we found out the fixation's great. The proximal fit and fill was amazing, but you probably didn't need, that last inch, let's call it. And then again, with people going through the front more often, a little bit of a more anatomic curve to the proximal femur, I don't think the intent was for it to be more forgiving and varus, but that's surely what ended up happening. And the triple taper. So, you have your dual taper, maybe a little bit rounded at the end, with the earlier version of the stems, but now these triple tapers, they just fill proximally so well. I mean, the first time I saw one was in fellowship, because where I trained, it was just type 1 stem, type 1, type 1, type 1. And right away I noticed the AP fill of these things was amazing, right? And I saw the value really early with like a valgus neck, and we can get into what's great and about them and what's maybe a limitation, but the AP fill was just noticeable right off the bat, and just the anatomic fill on the X-rays and a lot of these. I would say you look at them and you go, boy, that stem looks a little undersized, at least when you first start looking at them. You're not quite getting the fill that you're used to with these type 1 tapers. so, that's at least the triple taper background and design. But then you look at collared versus, no collar. And I mean, I remember seeing the collar for the first time and going, what is that thing? Like, this is cementless. Why are you trying to put a collar on something? That doesn't make sense. And, sure enough, all the biomechanical data comes out, just proving me totally wrong. I mean, that shows what a fellow knows, right? So that's just kind of the background, I think, the how we got here,
Yep.
in terms of my understanding and where we're going with it. I mean, I don't know. Bolo probably knows better better than I do. He's been part of the design teams for much longer than that. So
Right. Ball, Mike, what do you think?
Uh, well, I mean, I think I've certainly a conflict with one of the major companies on a STEM type like this. So, experience with double taper development from one of the major companies, and certainly utilization of ream and broach stems, like Bob was describing so well, that worked well. So, I do think this is where we're going to be for a while, Ira. And only because I don't think I'm smart enough to figure out how you'd make this better. Because I think some of those stems he talked about before, I mean, they weren't, they had pretty good track records too.
Yeah.
I think if you think about these things like use from the front, maybe the fracture risk with collar, it's broach only. I mean, I think maybe those things additive are having all those things in one stem type, again, available from more than one company. I think that's probably why it's clearly taking over sort of the market from the standpoint of utilization. If you just talk generically about triple tapers.
Jim, a couple of comments?
Yes, wrong group. And there was the tape lot group. Then there's the fit and fill group, and then there's Weimuller group. And the triple taper, like Bob was talking about, kind of incorporates for me everything that was great about all those stems. It gets rid of the stuff that I didn't like about those stems. So it's kind of everything we've learned in one design. And what I was attracted to, and the triple taper is not new, right? This has been around for a long time.
We talked a little bit. We talked about the stem, the triple tapered. I originally trained on the taper lock. Had a good track record. This looks like the next evolution, as Bo said, and Bob, you said that as well. Let's pivot a little bit into cement. All right. And Bo, why don't you give us an idea
Yeah.
of the indications? What's a slam dunk cement? What's a tweener? What's a never cement?
Try at our institution not to just do it just a simply age or gender or some combination
Sure.
of that. Now I think there's an age and gender where, or combination of age and gender where, and maybe on a lot of times we'll go to the OR and have both available, or both
Yeah.
options available, and then it's
Um,
intraoperative bone quality assessment. And so, I mean, sure, there's I guess I can't say I do an absolute age cutoff. There are certainly times, where the age is such, gender is such, bone quality appearance is such that I'll go in pretty heavily confident cemented. I do feel like there are some people that need to be cemented, and even when I go, Bob, this maybe be a debate point
sorry.
early on. It's probably even more interesting to say maybe counter to Bob. Bob, is there ever, what makes Bob, cement somebody based on what he told us, because I think I'm aggressive press fit, but maybe not quite as much as him, right?
yeah, I mean, I would say that first off, I think the data on hip fractures is pretty clear,
Yeah,
right? Like,
yeah,
and admittedly, I don't do that, but I'll do a prophylactic cable with a triple taper, and that's just, yeah, how I was, how I came through. So, that's a training thing. I would tell you that that's not, going to be supported by the data. And I'll be the first to admit that. So, people that are on dialysis, so you'll get in there and you'll have a neck cut and you can't even tell that the saw went through.
right, right.
That's someone on the rare cases I've had that I'll use a system that, I can either use a press fit or I can pivot over to French paradox type technique. So I just have a single broach system. It's so nice for me because the ins and outs of these taper slits versus composite beams versus this and that, I don't do enough cemented stems to be able to tell you, hey, this is the great technique for this one. So for me, just doing like a French paradox is easy. It takes kind of the thinking out of it for me. Those cases, I had one lady who, I should have press fit, elderly female, really deconditioned, hadn't really walked in several years. I didn't use a triple taper. This was years ago when I was using more of a Karai type stem, more of a compressive broach only. And she subsided early on. And so I didn't want that on her other side when we did it. So I cemented that, right? That was just a failure. Okay, learn from your mistakes and keep going. Those are pretty much, in my mind, hip fractures, super soft bone, compromised bone. Um, those are the ones that I'll do, but that's again, we queried it. It's kind of embarrassing at our institution. I think we had like 21 cemented hips between five of us over 5 years or something like that. So we just don't do it much.
I
Yeah.
have more. I think I have more than that. So
Yeah. So what are the negatives about in 2026? What are some of the negatives about cement? I mean, I'm thinking about certain younger surgeons, cement technique. I mean, when I trained last millennium with Dick Rothman, 50% of our cases were cemented acetabulum and cemented stems. So you learn cement technique, you learn cement. So are you seeing this decision making based on technique anywhere, Bolo?
yeah, I mean, I think you're really touching on an important topic. I mean, I think to do cementing well, Bob alluded to it. I think you've got to do it with some frequency, or if you're going to cement very infrequently, it's got to be a very forgiving technique and stem. So I mean, we have tried certainly at our institution in response to some of the AJR data, over the last 10 years to, I think be intent about making sure there's a reasonable percentage and the appropriate indicated patients to get cement technique, and part of that is for our fellows and residents and as trainees. Um, yeah, yeah. I mean, it's I think my even as I've tried to be more frequent with it, I guess I would say I still, I like a lot of people more comfortable just doing a cementless technique. But if you're going to get in that situation that even Bob conceded to, you gotta do it with some frequency to know what you're doing. And I the other part is like the people in the room know what to do to help you. I mean, you know that. I mean, right? It's
Yeah.
not just you doing it and doing an appropriate sort of third generation approach. I mean, it's making sure your staff can be capable in that setting too. So, I think we're going to try to make sure we maintain what, is acceptable percentage and volume for those reasons.
Bob, what
Yeah.
has been some of the really big advantages for you of this triple tapered stem in your practice?
It's just so forgiving. I mean, that's the crazy.
Define that for me. Forgiving.
You can use it in dysplasia cases. I would tell you that you're not locked in a rotation. I would argue you have 20 degrees and anteversion, retroversion. You can dial those things in because they're so filling. Now, once you kind of pick your trajectory, like if a fellow is maybe not broaching the correct way and you got to switch it up, that's a little bit tough. But if you set your anteversion or retroversion, whatever you want to do on, say, a dysplastic case right away, you're actually going to be okay. You're going to fill the proximal femur and it's going to work well. So that's an atypical case. In terms of just your standard cases, throughout the entire day, you can use the same stem and it essentially can work on pretty much everyone, at least in my practice. So you got your, door A, 30 some year old post-traumatic, scope guy that you're doing. Then you go to your 50-year-old, runner, maybe like door AB. The stem just fits on everyone. And the triple tapers, and I think a lot of people don't know this. I mean, the original one now that I say we would use, right? Well, we can say Actus, I guess, but that was a Riemann broach system, right? So, if you got a tight canal distally, you
Right.
can ream it. There's reamers. Um, so you won't get held up there. And then, door C bone,
Yeah.
albeit a higher fracture risk in literature, fills really well with the triple tapers. I mean, you get up to a size, in any of these systems, 8, 9, 10. That's just filling the entire kind of metaphysis and diaphysis. So uh, again, you could use it on pretty much anything. And I have some cases here what we can do later to kind of show you even on conversion nails, right? I use these things. So it's super flexible.
That's excellent. Let's flip a little bit to collared and collarless because I always thought that I like other people have said that, if you're not going to cement, if you're going to do cementless, what are you using a collar for? It's just seems kind of odd. But that thinking has changed. Let's take any of the faculty who want to take this on.
Let's try
Well,
Can you hear
Ballard.
me?
Let's try
yeah,
Ballard
we hear you,
again.
Jim.
See if
I
he's
had my T
recovered.
I had my TPA and I think my stroke symptoms are better. We'll see. I looked at a collar the same way. I was raised on a Zweigmuller stem a long time ago, and the first collar I saw was on a Karai, and I just thought it was a weird European idea. But it ends up, Bob mentioned the ignorance of being a fellow, it's the ignorance of being young. The literature is overwhelmingly in favor of collars for resisting or limiting periprosthetic fracture. They don't just resist axial stress, they resist rotational stress. And I think it's one of those things where the literature is so abundantly clear out of pretty much every registry you can look at that I don't even know that it's a debate anymore. What I was trying to say back when I had my stroke was the disease we need to address as hip surgeons is periprosthetic fracture above everything else. And implant choice is one of the only ways we can actually make a choice to limit that. And collars, both for cemented and cementless, I think are the way to do that.
Awesome. I Before you go there, we have a comment from Ahmed Siddiqui who can't unmute because he has a crying baby in the background. We call those junior residents, but it's all right. Um, So a recent JOA paper published a few weeks ago talked about 79% of patients with well-fixed triple taper stem have calcar resorption and collar overhang. What do you think this will mean clinically moving forward? Any potential pitfalls for these monotype stems in mid-term and long-term follow-up? Well, anyone want to take that on a little bit?
Yeah, I mean the collar, I think, and I think the stem they were talking about in that paper was Actus. So you guys can correct me if I'm wrong. I saw it, I just can't remember. Um, so if that was it, I mean that has a fixed collar length, right? So the smaller sizes are going to be more predisposed to having an overhanging collar with that specific design. I mean, with that said, you look at the registry data and it's like the best performing stem of all time. I mean, it's like a combined registry data internationally is a 0.6% failure rate over 7 years. It's ridiculous. So yeah, that might be a one downside to it. A little bit of overhang with the collar. I mean, then the Mayo guys, I think, just published their series. Looking at just even like 2 millimeters of overhang or something can maybe cause some psoas symptoms. There's going to be more studies coming out with that because I don't think everyone necessarily agrees with that. Although I mean, those guys are clearly, smart guys out there. And then the calcar absorption, I don't know. I mean, that's the sign of ingrowth.
Yeah.
And Bolo probably can jump on that just historically.
Well, I mean, I think it's like I agree about that, and no conflict with that particular study. I agree that it is that sign, Bob, and it's like other signs that are I guess we could say historically were concerning from the standpoint of the changes on the radiograph, but clear indicators of ingrowth with stems that precede a triple taper. So I think it's just the way the proximal femur may respond, Ira, to the stem design, but I mean. If anyone's tried to take one of these out, and that can be a later part of the discussion, I haven't seen any that were easy to get out. So, and I haven't seen tons that I've had to necessarily go back on, but a few. So I think I think that's something I don't have a whole lot of discomfort about.
All right. Sounds good. Let's go back to indications. Robert, you have a PowerPoint you want to show us. Let's look at some cases. All right.
Yeah, here, let me try to bring that up. I'll try to share my screen.
Okay.
Don't ask Ballard to do it, whatever you do.
Right.
All right. You guys able to see
Indiana
it?
Wi-Fi.
Yeah, I hear you, buddy.
Are you good? You can see it?
Yeah.
You may have to,
Yes.
we're seeing you. So, yeah, we're seeing you. It's fine.
Oh, here. How about what if I do
And
this?
presenter,
that's
but
good.
now you're good. Now you're
There
good.
you go. I unplugged my other screen. So, so this is one, and I guess, we'll go through, Ballard and Bolo on what they would do, but 89-year-old female, and she's healthy. This lady's taking less medications than I am. And she lives completely independently. She's widowed, has family nearby, bad hip. I mean, protrusio, right? So, how are you guys handling this in your practices?
Jimmy,
I
go
think
first.
she's got good, decent cortical bone for her age.
Yeah.
But Bob, I live on the other side of the spectrum from you. I find no problem cementing this lady, only because I think a cemented stem, a composite beam design by virtually every registry I know about, it's going to give her the lowest chance of a fracture. And as far as her quality of life goes, she'll do great either way. However, if you're going to go uncemented, you'd have to put a collar on it. So I have a lot of friends that would, and you included now, that would put an uncemented stem with a collar on that, which I think is defendable.
Bolo?
Yeah, this is one that I think I'm sort of in the middle. I mean, I'd be ready to submit. This person would go to the OR with the cemented stem available, but I do agree with what Jim said about the appearance of the cortical bone here. This is one that, like, I think I'm going to get in there and be comfortable actually doing triple taper, despite having some serious thoughts about doing the cemented approach. So maybe somewhere in the middle, because I got a feeling I know what Bob's going to do.
Yeah. So, so there is a design out now, and I'm not conflicted on this, so I could say, because I know, but you guys are, but you could use a single system that gives you both cemented and cementless options with this, collar, no collar. So that's outside, you template this, tell the fellows you could have both ready. But ultimately, and hopefully you're seeing the whole screen, I can minimize
Yep.
this.
Yeah.
Yeah. So ultimately, we go in, triple taper, prophylactic collar, or a prophylactic cable, right? So I do have a lower threshold to do this. Juranic's got some pretty reasonable biomechanical data from a little while ago
Yep.
that shows adding a cable really decreases the hoop stresses, and if it does fracture, it at least doesn't blow apart. I'm not saying it's going to prevent it, but it's going to probably keep you from a really bad day versus just a mild setback. And on her, some of these systems, I think broaching and how you broach is really important on these. So if you're using a triple taper and you're manually broaching, you're just going to clearly not use as much force. But if you're using these, either pneumatic impactor, these electromagnetic impactors, some of them have settings, and you could start on one, just kind of get a feel, how easy is this going down, work your way up from there. I will tell you, for the past however long I've had, the one with 3 settings, I guess we'll try to stay vendor agnostic. I finish every case on a 3. I mean, I finish every broach on a 3. Now that I've said this, I'm going to blow a femur up tomorrow. But we've not had an introp calcar fracture doing that. But I'm not starting there, and that's a very important point. I'm doing the last final couple hits on a 3 just to make sure that that's where we're at. So even on her, I did that.
I think the versatility of the system that we're talking about, where you can cement or not off the same broach, is really helpful as far as just efficiency goes. You can make a decision at the last second. But if you have to switch to an entirely different system, it makes it a bit different. But that's going to work great for that lady. I would just lean towards cement, because I don't know, I've seen too many fractures in my life to not be nervous about them, but I would have cemented that.
Yep. And then, okay.
So let's go back to Jim for a second. When you go into someone you're planning to do a cementless with a collar and what turns your mind to go to cement in that patient?
Well, when I made the neck cut and I've made the first broach pass or 2, and I get a better idea of how healthy their calcar is, how robust it is or isn't. And then if I'm questioning it, I'll look at their age. If they're older, leaning north of 75, and if I'm even debating it, I'll just cement them, because the cemented stem in its 80-year-old is going to last their lifetime in the absence of something strange. And so I lose nothing by cementing, but I gain a couple more hours of quality sleep.
Yeah, absolutely, absolutely. Without medications. Yeah.
Yeah, right. One of the things that, at least Andy Yang by us, who doesn't cement a ton, but one of Andy's indicators is if he uses a canal finder on every case. I do too. I just took it as a habit from Andy. And he said if I could just push that thing through with no resistance at all, I'm cementing. Like that.
That's good.
That's his threshold.
I like that.
Yeah,
Yeah, I think that's reasonable.
that makes sense. Let's talk a little bit about the instrumentation. Anything special? Anything the way you guys put in this triple taper stem? Any techniques to know about? What do you think?
Yeah,
The
I
one
mean,
thing I would
go ahead.
go ahead, Bolo.
Well, I mean, it's been referenced. I mean, I'm not conflicted with the device, but I have put all these in that I've put in essentially with one of the pneumatic impactors. That was a change for me, but in all honesty, I've enjoyed it from the standpoint of interesting upside is with trainees. It's nice to be able to sort of regulate impaction, truly regulate impaction. That's sort of unrelated to the stem. I do think, and I don't know the right answer to this. Maybe the other guys can educate me. A lot of people that are proponents of these stems propose, and it was Bob alluded to it, that they tolerate varus and you don't have to work so far lateral. I still actually work lateral as a posterior approach surgeon and do, and I mean, I guess I wonder if I'm not supposed to, because certainly if you talk to the zealots, they would tell you there's no need to do that and you can let it find its home, maybe slightly undersized, maybe slightly in varus. And I just, I'm still figuring that out, I guess, for myself.
I agree with Bolo. I'm a posterior hip guy as well, and I tend to emphasize going lateral. The only time that I would intentionally try to put it in varus, first of all, I don't get too bothered if it is in varus, is a really large male where it's going to be a challenge to sit the collar on the calcar. They have a really, really big femur, so I would cheat those into varus just to make sure I got contact with a calcar. And Ira, the only thing I would say technique wise that I worry that people will rely on collars as a primary stabilizer where it isn't. And they might tend to broach a little less aggressively. My broaching with this stem is as aggressive as any other stem I've put in, which is quite aggressive because if anything happens to that bone, I want it to be when I'm in the OR at that moment. Ironically, aggressive broaching doesn't ever cause that problem, but I broach as if it doesn't have a collar. And this particular stem goes down to the level of broaching every time. So I'm only using that collar as a secondary stabilizer of the implant.
Yeah, I mean, Jim, you nailed it there with if you're going to fracture during surgery, right? Like we had, I think it was 2 or 3 years ago, like a podium at ACUS showing our intraop calcar fractures. None of them were revised. And in fact, it was crazy. They had a lower revision rate than the non-fractured and their proms were better. I mean, I'm not endorsing cracking calcars, but if you do it and you catch it, they're going to do well, as opposed to a B2 post-op, which is just catastrophic.
Yeah.
So
I think what we all agree
okay.
on, Bob, and the word catastrophic, I'm going to go back to what I said before. Periparasitic fractures are the devil, and we have to do everything we can to avoid them.
Chris Dangles had a comment. Chris, you want to unmute yourself and ask your comment? Otherwise, I'll comment for you. All right. Well, Chris said the Karai worked
I don't know how to
fine.
unmute myself.
Oh, there you
today.
go. There you go, Chris. Okay.
Yeah, if the Karai worked fine on the opposite side, why not do the same thing?
Bob?
That's for Bob.
Yeah, I mean, I haven't used cries except in a revision setting. I've done nothing but triple taper since I've been in practice, so that's why for me.
I mean,
Yeah.
I'm,
Cry is a good stem. I've put a number of them in. I just find them technically more difficult to deal with. A triple taper stem like this is just easier and gives me the same result. I think it's a more difficult stem to use.
I've done exclusively Karai since 2005, and now I do Actus for door type 1 bone, champagne flute bone. So I'm drifting into Actus, but Cry works for everything.
Yeah,
Hard to
I
argue
think
against
it's great.
experience.
Getting
Yeah,
those out is even almost even worse than a triple taper, just because they ingrow so well, or I should say ongrow distally so well.
Yeah, but
Um,
they have the flutes for the K wires to slide down the side. I guess you got to do a few. I did a lot of metal on metal Karais, so yeah, you can remove them. Anyhow, just wondering.
no, no, that since 2005 sounds
But
like
you're
a long
but
time.
you're also dipping your toe in the triple taper water, and pretty soon you're going to be waist deep and enjoying it.
Yeah, I love it, but when I got the osteoporotic ones, I go back to the workhorse, the Karai.
Yeah, that's where I go to cement.
Let's uh let's talk a little bit about approaches for a second. Does this stem or any of these stems change your approach? Jim, you say you do a posterior approach. Let's talk about any anyone on the panel or in the audience using an anterior approach with this stem. See any difference, any challenge?
I think it's obviously super friendly to any approach. My
Okay.
understanding of the first is that it was designed more with an anterior approach in mind. Bob, you're from the area where that happened. Do you have a comment on that?
yeah, I mean in my opinion, it's probably the triple tapers are the most anterior friendly approach or stems. They have, if you could see my mouse and if it comes in, but it has that nice relief in the shoulder there.
Mhm.
The impaction coming in right through here is very easily accessible. The little bit of an anterior curve, or I should say, the little bit of the bow in the stem really helps you when you're coming to the front, especially if your starting point, is going to be right about here from the anterior. You want to be a little bit closer to the collar or to the calcar and broach from varus into a more straight shot down the canal, I think is how a lot of people do it, as opposed to just lateralizing off the bat. We'll broach from varus into more of a straight alignment as the stem gets bigger, typically. But those are just little technique pearls. This stem works with anything.
Bo, what when you cement, you use a collarless collard?
Yeah, so a little evolution for me. I mean, I think I would say, years ago, let's say 10 plus years, 10 plus years ago, probably collared. And then, I went through a period not with the triple taper stems, but one of the company's stems that was advocated to be used for a French paradox approach. And that's sort of more like the last 5 years. And so, now I guess I'm trying to figure out with this newer system, what will be my cemented stem of choice. Again, full conflict disclosed. This one does have two cemented options, but I don't think it'll always be the one that has two or the only one per se. So I think that's still a decision to be made by the surgeon. Your preference is probably maybe more cement technique, whether you're French paradox or you're somebody really wants to make sure you develop the bone prep in a way that there's a true mantle. And I think that's all. That's for sure a whole other JOEI um,
Yeah,
a webinar for sure. You've probably already done that one, but
yeah,
but
yeah.
that's sort of where I am. I guess I'm still figuring out, with my move to triple taper, what's going to be the cemented stem option I select.
When you move to a triple taper, what is there any advice you give someone who's been using a uh, loose type stem, wedge type stem, or standard old taper lock stem? What advice do you give, a young surgeon who comes up? I'm thinking of going this way. I'm used to this. Is there anything special you have to know? Because, again, if you put it in 20 degrees of antiversion, as Bob said, you may be stuck, so
Yeah, I tell the type 1 guys, do not fill medial lateral like a type 1. You will crack something.
Yeah, that's good. That's good advice.
Because the A
The
to P,
advice I would give,
go
I'm
ahead.
sorry, go ahead, Bob.
I'll say because A to P it fills so well that the first fracture I had in practice was really early on, probably my 3 months in or something. And I cracked the anterior. I mean, it was a big crack too. It went below the lesser. I blew the entire caliker up because I was trying to fill, medial lateral. I was chasing it on a varus neck, like a coxavera, where a coxavera would have done well. Don't do that. I mean, type one, you got to do that. Type or a triple taper, don't do that.
Yeah, I follow the version of the native neck, so I don't run into that problem. It can give me cup issues as far as combined version goes. The one advice for this particular stem, again, I have the same conflict as Bolo, is the proximal coating is very rough. And so every stem that we use has a personality. So when you come from like a cry or an Evan complete type stem, those behave much differently going in than a triple taper, which behaves very differently than a wedge stem like a taper lock or an accolade too. So this particular stem, that coating grips very early in the thumb insertion. So when I thumb insert that stem, it sits up a centimeter above the cut surface of the calcar. So it takes quite a few hits to get it to go down as that grabs that bone because it fits so nicely in that proximal femur. And people that are used to 3 taps and the stem is down can get bothered by that because they're not used to hitting the stem more than a couple of times to get it to seat. So when transitioning to these, I would just tell people that that fit requires a little bit more of work to get it down.
It brings up another point of what if, if you have a collar stem with this design and it doesn't seat all the way down to the neck. You worried? You're not worried? Jim, what do you think?
Having been benefited from being in a lab a lot with the stem, I've got all the confidence in the world that it goes down. And so I hit it until it goes down. Haven't run into a problem with that. Other collars that I've used where they sat up a millimeter or two, if it's truly not going down, I haven't worried about it. But then, of course, you're putting in a non-collared stem, which I did for years, and it went fine. But I would say with this particular stem, it will go down. You just haven't hit it enough if it's sitting up.
Yeah, I don't want to disagree with Jim because I think he's one a dear friend. I do think there's still a risk, right? I mean, I think you could prep it up to where Jim's not giving himself enough credit. I think this thing works really well in his hands, or any triple taper would. But I do think that risk is real. I know some some great hip surgeons that have probably have left a collar high. But I think that does come from if you over prep, if you will, over lateralize and try to get too big. And so I think that is one of the learning curves for this thing is, I guess I would say, I suspect if there was some way to compare, I probably am less aggressive with the broaching up with this stem than I was with a double taper, stem like was discussed earlier. That's just, that's what I think in my hands doing it. So I think that risk is still there. Now, would I worry about it? No. I mean, if I've restored head length or, length and offset appropriately, I'm not going to worry if it's up a little bit personally. I mean, I'm not going to love the x-ray or whatever, but I'm not going to worry about it.
Bob, what do you think?
I'm same as Bolo. I mean, the X-rays look stupid, and I hope I'm not like I hope I'm not the shortest ball length, right? Because then I do try to hit it down, because I don't want adding 2-3 millimeters of leg length if you don't have to. But otherwise, if I was going to be at like a zero ball for this system, I'll just stay to 3.5. I'm fine with it sitting up, not a big deal.
All right. Brett Blackburn, you want to unmute yourself? You have a question, Brett? I'll ask Brett's question for him. Do you run into issues where you feel like you're looser proximally when broaching, but tight distally? What do you think?
I haven't had that scenario. Now, Bob, I suspect you could.
That stays open, bro. I don't know, but yeah, it's right here where this.
Whoa.
Yeah, bro.
Yeah. Hold on. But I do think, I think Bob was talking about there is a triple taper stem that had reamers to address this. I mean, so I think it's a possible scenario. I guess what I'd do is if I was really worried about it, I'd appreciated it. I would use some sort of straight reamer to get distal, exposure. But I wonder, and again, I hate advocating about this because I'm learning myself,
I
but
think it's still unlocked, but
Oh,
yeah.
this idea that you are maybe again tolerating under prep, slightly undersized, slight varus, maybe keeps you out of those scenarios. I think.
Yeah, I mean, if you've got a really tight, like
Dore.
type 1 canal or type 1 Dore canal, and you're sizing it to like a 0 or a 1, that's where I think having, the system where you could broach on a, power of 3, the hammer goes to a 3. That's just what I use. When I was using Axis, I was using Concise and everything, but that'll usually get it. And as long as you're not toggling the broach on your way down and losing your proximal metaphyseal fit, because that's a problem. If manual broaching, I think it makes it more prone to do that. But as long as you're not toggling on the way down and you have your proximal metaphyseal fit, you're gonna be good.
Alex Patek, you want to unmute and ask a question?
Yeah, I was just saying that talking about the comparison of the Corral or Avenir between in the tipper table. I mean, I used to use the Avenir and I loved it, and I just recently changed to the tipper table, and I like it. It's really good, but I think the proximal part is too big, a little too bulky, and which I didn't have that problem with the Avenir, and I'm being more proud than I wanted to. It's harder to get in. If the collar is the protective part, what's the difference between which one? Why is the triple taper better than the Avenir or Coral?
Yeah, I mean, I make take a crack at that. And again, I think and again, I'll speak generically about triple tapers and maybe you're not worried about this, Alex, but I do think that proximal geometry where you say it may give you some trouble, it's probably protective for you in some cases, meaning, sort of those cases that may be more on the, sort of transition zone for cemented to cementless, cement less to cemented. So I think that's maybe, I don't know that I mean, you may have been able to make the Avenir work in those cases very predictably. Of course, I know there's a cemented option there too. Um, I think but I do think that's what I think about. That's how I think about the proximal geometry of this stem. Again, appreciating your comments about the geometry points you've raised. For me, it's actually something that gives me sort of further comfort, say for me, compared to a double taper stem. I mean, that's my transition. But that's sort of what I feel better about it, but that's my perception.
I think that's also what Jim was talking about, though, with putting the stems down, right? Like with, Cry, Avenir Complete, Avenir, when you put those stems down, you get that thing 95% seated and then it's a couple taps and it's down. Whereas, with these triple tapers, I mean, they sit up a little bit. When you're hand pushing it down, then you got to hit it. So that's why. But in terms of why is it better? I mean, I would just say every registry across the world is essentially showing triple tapers as the number one performing stem over, the past 5 to 7 years. So it's just it's the data showing us that's all.
And it's interesting, Alex, your point points out very well that the personality of stems and what our brains are used to. So I did Avenir Complete for a long time. And when I transitioned to a triple taper, it was a whole different look and feel. And so I wasn't accustomed to filling up that proximal femur as much as I did with a triple taper. But now that's the part, if you made me tell you one thing I love about this stem, it's how it fills that proximal femur. So I actually love that. The thing that's a hang up for you occasionally is the thing that I like the most about it, actually.
It's definitely a different feel. But let me just say one more thing. Before the Avenir, I was using a fit feel with a bigger proximal body. In this case, it was the Echo from ZB. But so I'm used to that bigger proximal geometry, which is similar to this Tipper Taper. But with that previous stem, I used to ream, and with this one, I'm not reaming, so it makes it a lot harder to get it in. I agree, but as you were saying, that is part of the protective aspect of this stem.
Right.
Ahmed Siddiqui, you still have kid issues? You want me to read your question? I'll read it. It says, "Are you guys allowed to talk about the different triple tapers available on the market. Yes, everyone's allowed to do that. I'm giving everyone permission. All
Wow.
right. Wow, absolutely. This is a Joey night. Ahmed said I've used 5 different triple tapered ones, and they all feel a bit different. Pros and cons on some on the market. Anyone want to take that on a little bit?
Yeah, I mean, I think, yeah, I mean, I think you're at a point where there will be subtle differences, Ira, but I have to tell you, my guess is if you got to where, you were comfortable with one, you would develop, you could easily get comfortable with another one. And I say that as someone with a conflict. And I do think knowing what I know about the design, again, there's some differences in collar geometry. There are some differences in, things we talk about the coating, and I think there's probably even some differences in the shape, although I'm not sure they're that different. And certainly brooches, there's probably some differences in the brooches, right? Sort of the theory behind the brooches. Um, um, but I don't know that there's enough like I think they're all going to perform really well. And I say that as someone with a conflict. I think more than one company is going to be able to demonstrate the excellent results that Bob's talking about in the registries. It's not only going to be one company. That's my take. And I hate to do this, but they're calling me to the OR, Ira, and I
Yep.
just want to thank everybody for letting me participate, but I don't want to hold them up. And if there's a way for you to allow people to communicate with questions afterwards, I'm of course open with that. You can share my info.
Thank you, Bo. Thanks for coming on
What a
board.
pleasure, you guys. Teach
See you,
Bob how to
Bo.
cement before this thing finishes.
Yeah.
Heresy.
And
That ain't
Ballard
never gonna happen.
and Ballard how to get on the internet. Thanks all.
That's
Have a great
right.
evening.
Yeah. So,
No, I'll
yeah,
add one thing to what Bolo said. The,
absolutely.
the the designs they're talking about. So they're the most similar designs are Actis and Z1 for the body. The most different are Insignia and the cattle stem from Smith and Nephew. Then there's the other stem that Exactech was selling that I can't remember the name of it. So there is a difference in feel between the Actis Z1 group and the Insignia and the cattle stem group. Those other two stems just have a different proximal design than Actis and Z1 does. So that difference is real. Whether it's clinically significant or not, you'd have to use it to get a feel in your own hands. But I think Bolo's right. I think this triple taper additional to the collar is a step up for any company's portfolio.
Yeah, the biggest learning curve, I think, between all those systems will be the necks. They have different neck angles. Some of them have variable neck lengths. So Actis, for example, every 2 sizes it jumps up. And then even between, like, I forget, it's like a size 4, it goes from like a 6 millimeter to 8 millimeter when you go to high offset, whereas ZB system is just the same neck lengths, 0 through 9. Um, and they have a Coxavera option. So the utility of the stem, each surgeon can kind of have little tricks of how they want to manage neck lengths, ball lengths, high offset, low offset. I think that's the bigger differentiator between the systems rather than the triple taper. I don't think that the taper itself is a huge differentiator.
All right, we have one last question with Dave Wexler. Dave, are you able to unmute and ask your question? I think it's an important one. I'm giving
I just wondered what the panel's views on polished tapered stems, such as am I allowed to say the word Exeter?
Yes.
Yeah. It's got at least 50 years of data and history, and some people, that's the only stem they use. But just wonder what your general views were on that technology.
I think it would be incredibly unwise to ever argue against the Exeter. I mean, I don't know of a stem that's got a more storied history than the Exeter, or more staunch believers and defenders of that technology. So I wouldn't argue against it. It's technically more difficult for those of us that don't cement as much. For example, as people in Britain cement, I think it requires a very strong hold of the cementing technique. Some of these French paradox stem designs that are collarless and polished as well are just technically easier to put in.
Excellent. So I'd like to say this is always the fastest hour in orthopedics. All right. I always like to say even Charlie DeCook can't get 6 joints done in this hour. All
I
right.
can't believe you said that. That was funny. Charlie will love it. Charlie's like, I can do 8 while you guys were talking.
Yeah, yeah, right. Eight by
Yeah,
one. 8 by 1.
8 by 1. Yeah.
Yeah. But I'd like us to sum up. So let's start with Bob. You'll give us some final comments, and then we'll and Jim, you'll bring us home.
Yeah, I mean, I think that, ultimately you got to do what you're comfortable with in practice, right? How you trained. Like I said, I pretty much press fit everything. We have extremely low fracture rates at our clinic, but all we do is press fit. And so I think if you're doing it a lot, you know the high risk patients, you're more aware of it. You learn how to cable. You're gonna have, fortunately, a very low fracture rate. On the flip side, I think you at least need to know how to cement. That it's just a skill you need to have as a hip surgeon, period. So, and then knowing the data, right? Like you have to know when you're doing something that, like I said earlier, a hip fracture on an 80-some-year-old, the data is going to tell you it's probably a little bit of a lower risk of a repeat surgery if you cement it, right? So, you got to know that too. And if you think you're slick enough to get around it, that's on you if you get burned. So, um, that's my story.
Okay, Jim, take us home.
Um, yeah, I'm beating this drum again about periprosthetic fracture. It's important when we talk to people like Bob that uses uncemented stems for everything. That's a very high volume surgeon that's been trained that way. The majority of fragility fractures in the world are not put in by Bob Sershons of the world. They're put in by people that are covering call that might do 4 or 5 bipolars a year that might not even be hip surgeons. And so I think for the majority of us, when it comes to fragility fractures, cementing with a collar is, and again, we could go into pretty much every registry that I've looked at recently. Cementing with a collar and a fragility fracture is what you should do. I don't find, for most of us, again, taking Bob out of this, I don't find any really good defense for using uncemented stems, particularly collarless, and those patients. And then for the others, you just need to realize that when you are taking care of people, there's only so much you can do to limit complications, infections, dislocations, but stem choice has a lot to do with fracture. And I think putting collars on stems is where we're strongly headed. And as time goes on, I think that's going to be the predominant stem design that we all use predominantly for that reason.
This is excellent. I want to thank the panel and the participants who discussed. As everyone knows, we record this, we edit it, we put it on our YouTube channel, ViewMedi, Spotify, Apple Podcasts. It's probably on a billboard somewhere in Washington, D.C. Anyway, I just want to thank everyone for showing up and have a good night.